Welcome to the second module on pain. And if you haven't watched the first one, I definitely recommend just because we dive into the differences between pain and injury, nociceptors, and overall discomfort and define those and give them context specific elements. But today is more the approach that you take once you have that information and what you do in real world, real time situations. So it's the more in session pain response protocol that we are looking at here. And the ultimate goal is to just give you, as a coach, the ability to understand where to go with all of that. So, first thing, most important, makes sense as soon as I say it, but is to have purpose and tone. So, it's to give you a system really to confidently handle pain, discomfort in sessions and be able to be the source of guidance as opposed to you're not diagnosing by any means, but the source of guidance for somebody and the person that they can then trust because they are looking for guidance and help in this no matter what. The last thing that I think is really important is yes, that is our purpose, but how do we do that? It's through tone. Clear, confident, calm. We're not going to say that we know something. We are very quick to say that is a great question. I hope to find that out. Let me see what I can find for you. We do not believe that we know everything, and we're definitely not going to diagnose. But if we remain clear, confident with all of that, and calm, and use the techniques and phrases that we're going to go over here, we'll be more successful. So, first thing and most important thing is just don't rush the fix. I think what's one of the problems I see the most often is client is experiencing pain, true pain, right? And just remember the differences between pain and injury. Pain is a stimulus, a feeling, a response, whereas injury is an actual issue with tissue inability to tolerate something. So there's actual injury that has been sustained versus pain, which is just a feeling or a threat response. And so we always say that injury has to be healed, whereas pain can be unlearned, right? We can unlearn that there is pain in the area, forget that it was there, and not have it surface and just decreases over time. Whereas an injury actually has to be healed, right? And so that's why I always just say don't rush the fix. Start by gathering as much information as you possibly can. It's not that you're immediately going to change the exercise instantly. There may be so many other things you could have fixed it before it even happened. And if you just immediately change it, or dive into it, that is going to make that client believe that this movement isn't good for me, right? I'm experiencing some low back pain when I'm doing some squats. Oh, okay, we're not going to squat today. That would be not a typical response most people would go with. They'd want to see what it is, since that's what we're doing. We're just going to dive in. So we use a 4-point pain check-in. All right, so how do you feel? What do you feel? When do you feel it? And you can even dive in even deeper by repeating those on multiple levels of, okay, so tell me, what do you feel when you're at the bottom of that position? All right, so when are you feeling it? Is it on the up or is it on the down? Are you feeling it anywhere else outside of that movement pattern? Like, did you feel it before? Have you ever had this before? Did you feel it at home? Right. So these are so many pieces of information that we can gain that ultimately will determine what our course of action might be. We might find, as if we remember from the previous lecture, there are so many reasons why we actually experience pain that is usually stress, diet, sleep, all of these different elements, and that could be why, right? And the last thing that I find extremely valuable, once I've done all of this informational check, is rate it on a scale of 1 to 10. Because if they're like, oh, it's like a one, I'm like, oh my gosh, then why am I diving in this deep? Right. And so that can be a really helpful piece of information. And if they're like, it's a 9 out of 10, I'm like, whoa, that's actually a really high number. We may need to make some bigger adjustments. And that's why the pain scale of 1 to 10 is really helpful, right? And then the last piece, bringing it back in. What about the pain scale outside of here? And so if we do it from this way, then we don't lead. And that's where I usually see a lot of issues go happen for coaches, is that they're not asking these more neutral questions and getting the client to explain, but they're giving the client words. And they're like, oh, is it sharpshooting and stabbing? The client's like, yes, it is. Well, then we just changed the entire perception. And we know pain is more perception based. So, what do you do once you have that number? Well, that's where the pain scale I find is extremely helpful because it helps us more interpret where they're at with this. So, combine this number with kind of how irritable the sensation is. And then we can ask even further questions like, is it gone in 10 seconds? Does it last for 2 days? Like, that's going to be another part of where we're at with it. If they're telling me that the pain is in, they're like, it's just like right here in my arm. And I'm like, oh, okay, interesting. And I'm instantly thinking like, oh, bicep tear, maybe like some elbow tendonitis of some form. And then I find out it's in both arms, and it like kicks in 24 hours later, and it lasts for about a day. And I'm like, oh, okay, it's bilateral, and it's in the biceps, and it's after we did bicep curls, and it's called soreness. So welcome to delayed onset muscle soreness. So that's where that kind of goes. Really helpful is to expand upon is it gone in about 10 seconds, or last, like, how long does it last? That's kind of the question we can go with there. So what do we do once we have that number? 0 to 2, continue. I might just monitor form. I'm like, okay, let me watch how this goes. It's a safe range. 3 to 4, we're going to adjust the load, the tempo, and the range. We're going to talk about how. 5 to 6, we're probably going to end up regressing some movement pattern type stuff, and I'm going to really be watching their face for any type of grimace of any sort. And if it is a 7 or above, or if it is neural type pain, if they're saying like sharpshooting, stabbing, like radiating, I am going to stop that movement. And I'm going to refer out. I'll probably ask a few more questions. We might do some things for the other part of the body potentially, but that's where there could be some issues. And if you have anything that is like they're lacking, continence, their bowels are no longer in their control, or they're not able to stand, like, you stop immediately and you call 911. Goes without saying, right? So the pain scale is a really helpful one. Just kind of note that like 4 is kind of my tipping point where I'm like, above 4, I'm probably not going to want to continue with this movement pattern at this load and this tempo and this range. And I'm going to adjust one of those things guaranteed, or the move completely if it's above a 4. Also, I use that from a time frame. So that's why I brought that up. So if they tip into pain, and it's common, right? If you want to actually like improve something, you're going to have to lean into discomfort. Even if you're rehabbing, you think about a knee surgery, say you've got a knee replacement, and they've got to get you back for clearance to 120 degrees of flexion. I would love more, but that's usually where they're kind of like, all right, once we got you there, we'll send you on your merry way. And so a lot of times they're cranking on that knee. They're pushing down on it. You don't want it to go into that position, but they are like doing some manipulation to get it there. Well, what's happening? They are creating pain that is higher than a 4, and then it dips back down and you're okay. Oftentimes, it's pain that will last up to 24 hours. Our kind of triggers for us within our settings is if that pain is higher than a 4, we're definitely switching that movement out to some degree. We probably, if it's a 3 or 4, we've already adjusted load, tempo, or range. And if it lasts longer than 24 hours, so say we dipped up in that 4 level, maybe even a 5, and it didn't go away and didn't get better, then we pushed too hard. We did too much. We did too long, whatever the case may be. And so those are kind of your guiding principles to look out for and be aware of. So what do we do when it is in that 3 to 4 or slightly above? Well, the first thing we do is you just check and adjust form. I mean, how often is it a joint centration or a foot or hand pressure issue? Oftentimes, if we create pressure, so say we get a full foot to press down into the ground, we're not having the knees roll out or roll in. We're not having the back sway forward or sway backwards. It just carries up the entire chain. The full foot pressure aspect of a movement pattern can adjust everything. It drives some internal rotation, like you get some pronation of the foot, internal rotation of the tibia, the kneecap, the patella, and the tuberal tibia. Tibial tuberosity, I kept saying that word backwards, is going to be in alignment. And so then it's going to allow the femur to actually internally rotate, going all the way up to the hip. The pelvis is going to be able to counternutate. Like, all these wonderful things are going to happen just from proper foot pressure. And they're like, oh, this feels great. And really what that is joint centration. All the joints are lined up. So we're not trying to like pull something in the wrong direction or rotate something that doesn't want to rotate in a certain direction. So let's just check form first. I mean, how often a push-up, the shoulders hurt, and we just find we just need to pull the elbows in so we get the scapulas to actually slide better on the rib cage, and we're not just compressing into the acromioclavicular joint. And they're just grinding away up there, right? So oftentimes it's just a form thing. So that's what we're going to do first. Hey, let me watch your form before we jump in too far. Let's just see where kind of form's at and see if I can clean anything up, and then let's try from there. And that's where I use let's try. And let's try this. Let's try pushing the knees up. Let's try full foot pressure. Let's try this. This is your opportunity to play. You're not saying you know what to do. You're saying together, let's try, right? Say that still doesn't work. What's our next step? We need to adjust the load, or we need to adjust the stability. So we check form down here. You got our little guy like cueing our overhead presser. Ideally, it would be a squat, person based on all these other exercises. But then you got the little weight here that's dropping down. We're going to drop that load. Well, say they're squatting 135, and we drop down to 95 just for simplicity. And so then they're doing that 95, and they're feeling better. Well, then we know it might just be too much load, and it could be systemic load on the entire system, the central nervous system, that is eliciting the body's inability to feel safe and then therefore initiating pain. We know that that's how that works, right? And so if they feel safe, they don't feel that threat response, that load is a better place. And then we can go up from there eventually. But maybe it's a stability thing. A lot of times, we just talked about full foot pressure. Say we are doing a split squat, they're unable to create full foot pressure in that front foot, and the knee is having a lot of pain and having a lot of issues. We have them go on to maybe some hand supports or a suspension strap to be able to hold on to, that just gives them that sense of security. It has actually, increased some overall points of contact. So stability has gone up. It's creating more pressure and tension within the entire body as we squeeze a handle to any degree, which is really nice. Our entire fascial system is actually going to be more engaged as we create that more closed loop from that regard of hands all the way to feet. And so then we could just, by giving them more stability, give them more of a sense of security, and the pain goes away and then they feel great. Right. So adjust the load, adjust the stability is our second step. Now you taking down the load, you've added some stability. Let's go with our squat analogy, right? And then we're maybe we did like a Hatfield for our squat. So we had them holding on to the safety squat bar, and you're like, man, we went lighter, still like not feeling good. Well, then we adjust the range. So now we don't go as deep. And maybe we use like a box and even a box plus pads so that they are not going down as deep. Let's see if that solves it. A lot of times it's just more than the Golgi tendon organ, which is going through, or the muscle spindle fibers, want to signal to the brain that it is safe to go to. And it's feeling that stretch, or it's feeling that quickness of the stretch, and it feels unstable and unsafe. And so then it's sending a signal to the brain that says, don't do this, don't go down here, we're going to have problems. And so if we adjust the range and we just decrease how deep we go within that, we may start to feel safe. So that would be our third step to the modifier. We're not going to change the move. We still really want to target the squat movement pattern for this person. We want their quadriceps and their glutes to be doing what they are meant to be doing. So we have just gone through, or we've checked our form, we're good there. We've decreased our load. We've increased our stability with some hand supports. And now we've adjusted and decreased our range, but we still really want to do this move. We don't want to just go jump and swap the move. We want to get as much of this as possible so we can get back to it at full capacity in a short amount of time. Still doesn't work. Now we're going to swap the movement. So we're swapping the exercise, but the key is that we're only swapping from a pattern-based exercise, so we still target the same muscle group or the same movement pattern. In this example, obviously, I have no load and all this kind of stuff, and they're doing, a squat, body weight squat. But if you think about it, maybe it's that they are going to do a wall sit, because with a wall sit, now we're not moving. We're isometric in nature. We're fully supported with our back and our feet. Our shins are going to be a little bit more vertical. We're going to isolate the quads. And so we're getting a similar movement pattern to the squat without too much deviation. And I can get time under tension, and I can just teach the body how to lock in within that and hopefully drive some more neural adaptation through that time under tension. Beautiful thing. Still doesn't work. Still pain. Not going to happen. Not happening today. Then we want to train the antagonist. So then we want to train the opposite muscles of those joints. So say it was a knee issue, then we're going to go to an RDL. So this is our last thing on the train. And if we do an RDL, the beautiful thing is we know that our quads are going to now become the antagonist to our new agonist. So our new muscle main group that is going to be working is the opposite of the one that was. So originally with our squat, the hamstrings were working very hard, and our adductors or inside thighs, to stabilize the actual pelvis, to stabilize the knees as we were going up and down in this squat pattern. Well, simultaneously, the quads were doing the majority of the work to get us back on up. We flip it. Now we're targeting the hamstrings, so therefore our quads can still be engaged, but their goal now is just to stabilize, not to actually perform the actual function to move the body from insertion, to move that part of the body from insertion to origin, right? So when we think about that, we can always regress it even more and have them do some type of hamstring direct isolation work. But that would be the direction we would go. We would first adjust form, then we adjust load, then we adjust stability, then we adjust range, then we swap the exercise, the same movement, the same pattern. This could be leg extension, right? You could progress it all the way down. So you're still activating that. It could be a really good thing. It's very common with APT. And then if we need to, we're going to hit the antagonist. But so often I see where you're like, oh, this dumbbell bench press hurts. Okay, well, let's row. We just immediately go here. We flip it. We go to step 5. Go through your steps. It'll make the client better. It'll take away the risk. When we're doing it, we want to think in terms, when we are making the change to a different exercise, we want to think local versus global modifications. Like modifications aren't just regressions, and I think that's a common thing. They're opportunities to really, for you to get creative more than anything else and help maintain progress with less risk. And that's your job, is to mitigate risk within those things and build confidence so that they can ultimately yield the result that they are after. Now, if it is a local modification, that's where you're doing something to just change the grip. I mean, how often have you had it where, say, a pull up overhand hurts, but you put them in an underhand chin up grip and they feel great? Or you take a bench press, for example, and you give them dumbbells instead, and you put them at an angle, and all of a sudden that shoulder feels great. Or you bring up the bench, or you drop the bench down, whatever the case would be. We all have these different points where changing the grip, changing the angle, or changing the depth is the solution, and it's usually for whatever like local joint issue that it may be. If we're having overall issues within the whole thing, then we want to go a little bit more global. And that's where, like, all right, well, let's go to sleds. Could be like a reverse sled pull, could be a great global modifier for a squat. We're getting some movement, we're getting some blood flow, we're getting there. I mentioned the isometric within my example there that we went with a wall sit. And it's really, if it's more of a systemic central nervous system thing, or the body is under a lot of inflammation or just locking up, quote unquote, then we might just want to just focus on some breath work and just getting the body to down regulate a little bit, come off of a couple of dexters, right? So let's look at our coaching tree. And I feel like this just kind of expands on what we just did. But first, you get the client to report that pain level. You ask those 4 questions. And then if they do say sharp, radiating, or numb, just stop. Like, it's not worth it. That means that something is really there. Definitely ask questions, but don't be like, oh, let's just check your form. Let's just see what's going on here. This is our like quick to filter. And we're like, okay, we're going to stop. Something's threatening here. We need to change what we're doing and adjust. And if not, then that's where you adjust, but you adjust through the 5 steps that we just went through: still present, regress, or refer. So if at the end of that you're still feeling stuff, you can keep regressing further until they maybe just doing breathing work on the ground. But really, you're just like, I need to refer. It's as simple as that. So that brings me to the other red flags for referral, because we just talked about referral. Like, so I mentioned the numbness, but it also means tingling, burning. These are like big concerns, unless it's a muscle feels like it's burning and it's just because they're doing a lot of repetitions. And that's where that question that I brought up a while ago, does it go away in 10 seconds? Like, tell me how long it lasts. Well, if it stops the moment they're doing it, that's probably just muscle burn, right? We're probably okay. Is sleep disrupted by pain? Shoulder is my best example for this. A very common tell of a torn rotator cuff: if somebody lays on their back and it wakes them up, say you're a side sleeper, people often think, oh, I tore my rotator cuff, or I messed up my shoulder side sleeping. What's interesting is because then when we sleep, our body relaxes. And so we're no longer engaging muscles to the same degree to stabilize and hold postures within our body. Even if you say, like, I've got horrible posture and I lean, yeah, but your body is still working to hold that posture. You're still in that moment. You're still fighting a relationship with gravity, right? Gravity is pulling upon you and you're trying to sit up and stabilize. Now, the more we have these giant, soft, cushy couches and chairs that literally take our body from needing to use a single muscle to do anything. Eventually, it'll literally just have something that attaches to our chest and lifts it up and down. So even our diaphragm doesn't have to work. It'll just like help our lungs pump themselves. I digress. I got a little down the whole negative there for a future society. But ultimately, like, if pain disrupts our sleep, we know that something is seriously wrong. And a rotator cuff is a good example of that. You can fall asleep on your side and be fine. You wake up when you're on your back, because then it's pulling that shoulder girdle open, right? And so then that's where it is feeling that stress, usually on the supraspinatus, which is the most common one that ends up frayed, like lightly tore or full separation to full tear. So that's just a good gauge of like, oof, nope, it woke you up when you were sleeping. We need to go see someone. When I respond that way, like, oof, right? But that's just something. If pain worsens with every rep, even after you go through all of those things, like definitely stop, see if it comes back after that, and if it does, then just refer. Right? Swelling, bruising, that's those are concerns, right? And obviously like instability with something, if it can't even hold stability like while it's there, that's a problem. And then pain that doesn't respond to all those regressions, which kind of makes sense. Like just remember, unless you're an actual physical therapist, if you're a coach, personal trainer, anything within those regards, like you are a movement professional. You understand movement. You understand the human body. You understand joint mechanics. You understand biomechanics. And because of that, you can make really good quality decisions, but it doesn't mean you should always try and treat. Right. So the main thing for us is just to know that our words are going to change how that client's brain literally interprets the situation. So we want to speak safety into a session. That's how I like to word that. Speak safety into a session. Like framing really does create ultimately or dissolve that fear that a client can have. So if we just say things like, all right, let's just train within safety potential today. All right, that's helpful. Let's adjust a little bit. Like I'm making it like, all right, sounds good. I appreciate you sharing, right? And I said that in the last presentation. Perfect. It's exactly very much helpful what I was kind of looking for. So let's go try this. Let's try this position then. All right, sounds good. No, that's very helpful. And they could have told me it was like the worst thing in the world. All right, cool. That's very good. Helpful. Not a big deal. We want to avoid leading them. Is it stabbing? Let's not break you. Let's go light today. Probably my two biggest pet peeves. All right, let's just go light today. Now we're telling them that when something is uncomfortable, we go light. Not a good thing. We want to reach their max potential, their safety potential, as I word up here, for that day, because it's going to be different every single day. And we don't want them to be like, oh, something is wrong. So they actually want me to go light. All right, let's go to your safety potential day. How's that feel? Scale 1 to 10. Sweet. All right. Yeah, let's keep it rolling. Do you want to go up by 5? Do you feel like staying here for another set? What do you think? Give them suggestions, give them ideas, lead in that sense towards outcome based, not lead towards avoidance based, and we'll be good. And then afterwards, what I find extremely valuable, and I don't think it's done enough, but just audit yourself. Think through your sessions. Like, did I ask open ended questions? Did I modify before removing something? Did I speak with calm, confidence, clarity within the session? And did I try and get the win? Heck yeah. So stoked we were able to get through another session. We got some good work done. I know you weren't able to do the squats you wanted, but we rocked everything else. And like, shoot, most people would have stopped. So definitely a huge win. I mean, I can make it hyped up positive when, no problem at all. Super happy we actually went through the entire movement pattern, even without load. We're definitely like going to be speeding up the recovery process, to get you back to where you want to be. Simple as that, right? Record the notes that you come up with for next time. So summary: ask, adjust, retest. Right, that's the simplest way to put the thing. Modify with purpose, like actually have a reason for it. For when needed, and know that pain is not a sign; it's just a guidepost. All right, onward towards more individual specifics with shoulder issues, knee issues, back issues, and all of the other wonderful topics.